Good evening, sir. Thank you. Thank you for having me here. It's a great pleasure to be here.
સંદીપ ભાઈ આપણે મળવાના ક્યારે બાકી છે ને?
હા એટલે
અત્યારે ડેટ નહીં બોલતા. મારે આશીષભાઈ જોડે વાત થઈ હતી that we will meet, so even this weekend is fine. This weekend also is fine.
તમે કહેશો એ દિવસ સર નાઈટ માં મળીશું. હું ફ્રાઈડે સેટરડે સન્ડે નથી સર.
Okay,
so we are live now. So on behalf of NNF Gujarat, I, Dr. Prashant Karya, welcome one and all to today's Neonatal Pathshala. This Neonatal Pathshala is a unique in a way that today we are having a Neonatal Nephrology CME. For more details, I invite President Dr. Sandeep Trivedi to welcome the audience.
Thank you, Prashant. I welcome to you all, and thankful to Dr. Somsekhar sir and Dr. Ashish Mehta sir who are giving guidance to us every time. And I welcome Dr. Suksham Jain, Dr. Rahul Verma sir, Dr. Tanushree, and Dr. Uma Madam, Dr. Purva, Dr. Phagun, Dr. Vishnu, and Dr. Divyang Patel. And I welcome also the audience, those who are participating. And this program is very useful, and so many medical colleges in Gujarat and also outside of the Gujarat, they give the break 3:30 to 4:30 to all the medical PG students to join here. Thank you and welcome all. Thank you very much, Prashant. Hand over to you.
Thank you so much. So without taking much of a time, I introduce our today's first speaker. She is Dr. Suksham Jain, Professor and Head, Department of Neonatology, GMCH, Chandigarh. Ma'am is working in Level 3 NICU, which is the 25-bedded NICU, and running fellowship and DM courses over there. Most interestingly, she is running CLMC, one of the first human milk bank of North India since last 2016.
Dr. Uma Maheshwari and
just a minute. And she is having more than 50 national and international publications and 3 book chapters. So I invite her for today's talk of antenatally diagnosed kidney diseases. Thank you, ma'am.
Thank you, Dr. Uma Maheshwari and Dr. Prashant. And topic for today's discussion is on antenatally diagnosed kidney disease. And it's one of the most common antenatally diagnosed entity, and often we get a referral from antenatal.
We can hear you, ma'am. We can hear you. The slides are not moving, but we can hear you.
My slide is not moving. I don't know why.
Just click on the slide at present and then down button.
It's on the slide only, and it's not.
Click it over there once.
Done.
Yeah.
So we will be covering about the disease load and how to diagnose antenatal, and then postnatal follow-up along with the investigation and managing the specific condition. So I'll firstly cover the salient features in the beginning and then would revise them in the end, just to appraise you with the fact that the incidence varies from 1 to 5%, and maybe even varies from ±1% here or there in developing or developed world, because the inheritance of it is multifactorial. But in 80 to 90% of the cases, it may be mild and it will resolve. So the apprehension of the parents has to be tackled very, judiciously after looking into the reports. And if you are not confirmed, then you may go for a proper ultrasound. And it's 33% pediatric surgery in PGI of these patients, and 1 to 2 years. And we'll talk about follow-up. If you talk to the
Prashant, can you share the slides and you can. Madam is muted. Madam,
you're muted.
Madam, you're muted. Prashant, can you share the slides and move it, and
Sure.
Madam can talk, might be easier. And
Sure.
Madam can switch off her video so that internet issues can be sorted out.
Sure. Ma'am, slides are visible. Ma'am, you're still muted.
Madam, please unmute yourself.
Ma'am, you are muted.
Okay. Am I audible now?
Yeah, perfect.
Yes,
Okay.
ma'am.
Okay, perfect. So, sorry, I'll restart. So we'll talk about the disease load so that we understand why it is important. And what do we get on antenatal diagnosis and how to follow it up on the postnatal along with the investigations, and then about management of specific conditions. So firstly, I'll talk about some of the salient features which we'll revise later on also, just to understand what is the disease load and how to go ahead. It's about 1 to 5.6% plus minus 1% here or there in developing or the developed world. And parents also has to understand that 80 to 90% of the cases are mild and they will resolve either in utero or once the baby is born in the neonatal period over a period of 1 month to 3 months. And it's a very easy rule of, because they will be apprehensive whether the child will need surgery or not. So 33%, 30 to 33% will need surgery. Rest 33%, this is for the moderate to severe only, not for the mild. Rest 1/3, they will need continuous antibiotic prophylaxis and has to be followed. And if you ask about the tail end of follow-up, it may be as long as the lifelong as per the pediatric surgeons. And then 1/3 of these will resolve over a period of 1 to 2 years. But if the disease is bilateral, then it's a cause of worry. Or if it's a single kidney and that is also disease, then also it's a cause of worry. So antenatal ultrasound, what should be the frequency? Once the patient is coming to you, if you don't remember anything, the diameters, what is the pathophysiology, cortical thinning, separation, we just have one ultrasound in 3rd trimester. And if it was initially severe disease and you got an ultrasound in the 2nd trimester also, then get it done every 4 to 6 weekly, preferably from the same lab where it was done previously. And this is not a condition where termination of pregnancy should be done, other than the fact if it is associated with some other major systemic malformations or other extrarenal threatening abnormalities. And if there is a lower urinary tract obstruction and you don't have a pediatric surgeon, best is to refer the patient in utero. So what are the other renal anomalies? Renal anomalies could be of a wide spectrum. Just remember there is oligohydramnios in the mother, and rest in the kidney you can have any type of anomaly along with the renal parenchymal thinning, which is seen in form of cortical thinning, poor corticomedullary differentiation. And a lot of time the residents get bugged up with the stereotypical line which the sonographer writes down: poor corticomedullary differentiation and cortical thinning. And there may be renal cyst also. In the systemic, you can have anomaly of the cardiovascular system, neurological, skeletal system, and you have certain soft markers also. So if you go by the antenatal hydronephrosis classification, just remember one figure. Instead of remembering so many figures, the most important figure is here: diameter, renopelvic diameter of 10, anterior posterior diameter of 10 millimeter. If you are not able to remember more figures, this is just for an exhaustive exercise and not to confuse you. And if you get it in the 2nd trimester, you can differentiate into mild, moderate, and severe depending upon the AP diameter of more than 10 or less than 10. In 3rd trimester, again, if the diameter, because it is telling whether the disease is progressing, severe, or point of care 3rd trimester diagnosis. So severity will be changing from moderate to severe if it goes from 10 to 15 millimeter of the diameter. So just remember one figure of 10 mm diameter and keep on following the same. Next. So on physical examination, you can have abdominal mass, especially in cases of multicystic dysplastic kidney. The liver may be, there may be palpable bladder, and this bladder is palpable once the child has even done the voiding. There may be loss of abdominal musculature, prune belly. Once you see a baby of prune belly, you are not going to forget it for the lifelong. It's like a spotter. Then ear tags or ear anomalies, spinal anomalies in form of meningomyelocele, single umbilical artery. These are some of the soft markers you should be looking in for. And this is the classification which has been given by Society of Fetal Urology, and commonly used short form is SFU. And here grade 1, 2, 3, 4. So the grading, just to memorize, as the grading goes towards the severity, there will be a huge dilatation of the renal parenchyma, and it will be thinned out once you go towards the grade 4. But as you go to grade 3, there is dilatation without thinning, and there is separation of pelvic calyceal system, which is mild and which may be appreciable in grade 2 and may not be appreciable in grade 1 because of the just a slight separation. So the management will depend upon this classification of ultrasound done for the grade 1, 2, 3, 4. Next, please. So this chart, again, as I told you, please remember just one figure of 10 mm. Now, antenatally, the renal pelvis was dilated, and the parents are also apprehensive because most of the time we tell them that once the baby is born, then we will look in for another action, because antenatal period, you are just busy with the counseling, and whatever the action, also surgical or non-surgical intervention, they are mostly postnatal only. So after 24 to 48 hours, there's no hurry in getting the ultrasound done. It may be delayed up to few days also. So you can go for examination by day 2 if for the certain specific condition in form of if there is a lower urinary tract obstruction, then you need it early within first 48 hours. Otherwise, you can wait for as long as 5 to 7 days. If it turns out to be normal, you can repeat the ultrasound as early as 1 month or maybe even 3 months. If that is also normal, there's no need to follow up. And here, remember, the diameter remains less than 10 millimeter. Now, the AP diameter is more than 10 millimeter, then what all to be looked in for? Also look for calyceal system, uretral dilatation, uretral wall thickness, pelvic thickness, cyst and abnormal corticomedullary differentiation. Look at the bladder. Is the bladder dilated? It's thickened. Is this dilatation of bladder and ureter with or without dilatation of pelvic calyceal system or not? Presence of uretrocele. Now you will need the center which is you doing vesicocystourethrogram, voiding and non-voiding both, because later on you will be also needing a voiding one where you will be putting the dye and looking in for clearance of the dye. So if this turns out, if you don't have it, better is to refer the patient to the center which has it. So if it turns out to be normal, then just examination at 3 months after birth, again using an ultrasonogram and diameter if less than 10 millimeter, then you can stop doing the follow-up. But if it is abnormal and pelvic diameter is more than 10 millimeter, or your voiding cystourethrogram is abnormal, then what you have to do is you have to do certain more investigations. Let's see what all these investigations are. Next, please. So this is just to ease you up, that you don't have to be very panicky, and you have to counsel the parents that there is no hurry of ultrasound. You may get it done urgently if there is an obstruction of the lower urinary tract, bilateral disease, or solitary kidneys disease. Within 1 week, if it was hydroureter, and you can delay it up to 1 to 3 weeks, depending upon the availability of ultrasound date, if it's a unilateral or bilateral mild disease. So for mild disease, the diameter has to be less than 10 millimeter. If you are running at a borderline of 8 or so, then you can maybe do it slightly early. Next, please. So micturating cystourethrogram. Problem with this is that you are exposing the baby to radiation, and itself it can precipitate UTI. So it is done especially in cases of the lower urinary tract obstruction and as early as 24 to 48 hours. But if hydronephrosis of grade 3, then you can wait for 4 to 6 weeks. So if you are dealing with this obstruction, lower urinary tract obstruction, which is mainly in form of posterior urethral valve, best is refer to a center which has got a good pediatric surgery backup, and you have got all these investigations available. So in cases of the mild, there is no need to, until it is worsening, there is no need to hurry. Then there is diuretic renography. This is done using DTPA or MAG3. These are the dyes which are commonly used. And if there is grade 3 to 4 hydronephrosis, unilateral or bilateral, as per the classification of SFU that we discussed on the basis of ultrasonography, hydronephrosis with dilated ureters. And it is done usually at 6 to 8 weeks and repeated after 3 months. So what all you look at, you will differentiate between obstructive and non-obstructive type of hydronephrosis. If there is an early peak by 2 to 5 minutes and complete emptying by 20 minutes with or without the use of furosemide, then this is not obstructive. And here the renal function which is taken as normal is 45 to 55% of the normal. Some of the centers may intervene at 40%, others may intervene at 35% of the renal function for the surgical intervention. So surgical intervention, as I told you, will be needed in lower urinary tract obstruction, obstructed hydronephrosis. If the renal functions are differential, they are deteriorating, and the bilateral hydronephrosis or solitary kidneys disease with renal function deteriorating to less than 35 to 40%. So VUR in a normal general population, it is less than 1%. But VUR in these cases may be very high. It may be up to 10 to 40% in cases of unilateral or bilateral disease. And you can suspect that VUR will happen if APD diameter is more than 10. So as earlier told, just remember one figure of 10 mm. If you're not able to memorize more figures. And but correlation with the grade is not there. And as far as antibiotic prophylaxis, the systematic review which has been done, and it's a controversial area, where in mild VUR, if you have to continue with the antibiotics or not, with and without antibiotics, the result has come out to be nearly same. Next, please. So in children where you have grade 3 to 4 dilatation, then in cases of boys, if there's a breakthrough UTI, best is to go for circumcision. And in patients with dilating VUR or abnormal renal parenchymal disease, you have to go for surgical ablation. In patients with high risk of renal damage, as in cases of febrile UTI, then you have to go for bilateral or cortical abnormalities also there. Then you have to go for a surgical approach for this. And also the children who have got a bilateral high-grade VUR and renal damage, which is already there at the time of diagnosis, needs a long-term follow-up. And here the long-term means it may be a lifelong follow-up. So this is just a diagram to show you how the grade 4 VUR looks like. So here you can see the whole ureters are tortuous, they're dilated, the bladder is dilated, and pelvic ileal system, again, you can't appreciate thinning on this because it's by the dye, and it's all dilated with separation of pelvic ileal system. Next, please. So another condition which is although not a common one, but maybe rarely present, as uretropelvic junction stenosis. So what is there is that renal pelvis is dilated by more than 15 millimeter. But here this dilatation of pelvis and calyceal system is in absence of dilatation of ureters and bladder. So when you are looking at the system, please look at in toto, ureter, bladder, urethra, kidneys, its renal pelvises and calyces all. And sometimes there may be perirenal urinoma, which is a very rare entity, and there are just few case reports on the same. If it's unilateral, go for a conservative approach. If it's not a unilateral disease, then we have to go for a renographic studies, and depending upon the diameter on ultrasonography, you have to go for the management. Early surgical intervention is not needed until unless renal functions are getting deterioration. More or less, it depends upon the deteriorating renal function that will decide for the surgery. So this is how it looks like on an ultrasound, where you have one of the other valve of the uretropelvic area undergoes stenosis and lead to uretropelvic junction stenosis. Next, please. So this is very important condition, and all the pediatrician during their PG, especially, they see few cases of posterior urethral valve. The child who comes to you postnatal is quite sick, and if the child is more than 48 to 72 hours, probably you have already missed the train by causing lots of damage to the kidney. The sodium will be low, your urine osmolality will be very low, and renal functions will be highly deteriorated. So best is, if you are suspecting it, send the baby in utero, or if you have diagnosed it, immediate referral to a higher center where you can confirm the diagnosis. So what happens is, there is a tissue leaflet which fans distally from prostatic urethra to external urinary sphincter. So when this fans out, it will cause a posterior urethral valve-like phenomena, and it is suspected in patients with oligohydramnios, where the bladder, even after avoiding or emptying, the failure of the bladder to emptying is there. You can palpate the bladder if the baby is already born. And if it is diagnosed early in first or second trimester, it has a bad prognosis, because here it is associated with the pulmonary hypoplasia, and you may not be able to salvage the child. So whatever in vitro management is, it is all in an experimental stage and is done only in a referral center which has got a pediatric surgical unit and is working efficiently on that. So the most common one is vesicoamniotic shunting. A pigtail shunt is put under ultrasonography. But even with this, survival does improve, but normal renal function is not there by 1 year. So one of the very big pediatric surgery unit we have in PGI, even there, what we have seen is that they are managing, if it is diagnosed within 24 hours to 48 hours, they'll manage, instead of putting pigtail shunt in the antenatal period. So preferred time of treatment is within 24 to 72 hours of birth. So catheter drainage, and please don't put the catheter on your own. Ask the surgeon to put it. You may damage the urethra. And do the renal function along with electrolyte, and continue with the antibiotic prophylaxis till further management, surgical management is decided. And here, vesicocystourethrogram is done quite early with the voiding view of urethra, and then catheter is removed to see the exact condition of the urethra. And endoscopic valve ablation is done if the child is medically stable. And then if catheter drainage improves the hydronephrosis and creatinine, then only valve ablation is done. But if it does not improve upon the renal function, they are getting deteriorated. That means we are dealing with dysplastic kidney, and then an upper tract diversion is done. And in smaller babies where the weight is less than 2 kg, a standby vesicotomy is done to release the obstruction. And once the child improves upon the weight, then you go for the further ablation. And this is how it looks like with a mega bladder, with diverticuli and posterior urethral valve in this case. So now the rare conditions, 1 or 2 rare conditions are there, and one is duplex kidney. It's not the kidney is double, but it's a renal collecting system that involves one kidney drainage that is duplicated, and it may be completely or partially connected or separated from it. And this type is associated with usually lower pole vesico-ureteric reflux also, which may be with obstruction or without obstruction. And diagnosed using ultrasonography or VCUG, which is done in these cases also, preferably within first few days of birth. And if we are not able to get a conclusive report, then we have to go for a renal isotope scan also. And a surgical approach is done if it's obstructive uretrocele. Here, uretrocele puncture is done surgically. Please. So this is a obstructive uretrocele in a double draining system, that is in a duplex kidney. Next. So just to touch upon polycystic kidney disease, This polycystic kidney disease, you can see the multiple cyst. It may be autosomal dominant or recessive. The prognosis is very poor, and it is associated with cyst in the other areas along with the hepatic fibrosis or pulmonary hypoplasia. And it's not easy to salvage such children even after multiple cycles of your dialysis. Next, please. Next is multicystic dysplastic kidney. Here, this finding is quite common, and if it is, and the cause is not known, some of it may be related to genetic polymorphism or some complicated gene. Here again, what happens is, if it's a unilateral, then nothing is being done. Slowly, over a period of 1 to 2 years, this unhealthy kidney will shrink, and the baby will lead a normal life in adulthood and later on with the one kidney. But if it is bilateral, then the survival is poor. So this is all I have to say. Just remember again the salient points covering that incidence is not rare. You will get lots of antenatal diagnosis, especially of mild and moderate disease, whereby the AP diameter is 4 mm, 5 mm, 7 mm. And you have to counsel the parents judiciously. And just remember one figure of 10 mm diameter, renopelvic AP diameter. And even if it is more, you have to tell the parent that surgical correction may not be needed in all the cases. It's just the 1/3 case that will need it. And if it's bilateral more than 10 mm diameter, definitely it's a cause of concern, but not for the termination. And if the patient has come to you in second trimester, get one ultrasound in third trimester to see how it is progressing. And if it is a bilateral disease and where the diameter is somewhere borderline 8 to 9, 10 mm, then go for every 4 to 6 weekly ultrasonogram to see how it is progressing. Is it static or progressive in nature? That's all I have to say.
Thank you so much, ma'am. I mean, you have finished in time and given all the useful information. As ma'am has to leave, anybody is having any question, they can put in a chat box and we'll just ma'am,
So in the
just
chat,
yeah.
the only thing was initially probably people were not able to hear.
Yeah. Now they are able to hear and everything is perfect. Only one question which came personally was, in a multicystic dysplastic kidney, you said that the kidney will be automatically, degenerate. So the next kidney, which is fine. See, the one case which came to us was a child with high creatinine. One kidney was abnormal, one was normal. So what to do in that case?
So you are saying that creatinine was high, the kidney which has been labeled as normal may not be probably normal. So this multicystic dysplastic kidney doesn't have any renal function, and with one kidney you are able to maintain the renal function. So either this kidney is not normal or the child has some other secondary reason for deterioration of renal function. Maybe child is sick, maybe child is dehydrated. Most of the cases the child is dehydrated. So that may be the reason. Once you hydrate the baby, then reassess the renal function. And if the local causes or the illness is not there, hydration is okay, then probably you need to repeat an ultrasound to see whether the other kidney is normal or not. Because here in this case, what we have seen so many cases of MCKD in PGI, and the only thing was they would do a repeat ultrasound at 3 months, 6 months, and this was just to see if the kidney is shrinking. There's no need to even surgically open and remove it. It will shrink on its own. This is what obviously pediatric surgeon can tell better, but this is what we know from the follow-up of these patients, what we saw in the PGI. In our system, we don't have we have just one pediatric surgeon, not a complete department of it. So we are referring them to PGI. So whatever I'm telling is from my experience while I was in PGI.
Thank you, ma'am. Somsekhar sir, yes.
Yeah, so I just wanted to share that for whatever reason many times if only a single kidney function remains, it is quite compatible with a normal life, and many adults go on without knowing that they have only one kidney and they discover it later on in life. So I think we need to be, when we counsel during neonatal period, we need to make sure that that is put across quite clearly.
Yeah, so thank you so much,
Thank
ma'am.
you.
And from NNF
Thank you, sir.
Gujarat, we are presenting certificate of appreciation to you in the beginning because you are supposed to travel. And thank you so much for
Thank you, sir.
being a expert in today's neonatal nephrology CME. So
Thank
this,
you.
yeah.
Thank you, ma'am. Thank you. Thank
Thank
you.
you, sir. I'll take a leave, sir.
Sure. Thanks, ma'am. Bye.
So now moving on to the second topic, we do have a wonderful speaker, Dr. Rahul Verma. He is MD DCH and then MRCP from the UK, and at present he is the head of NICU PICU of the HN Reliance Foundation Hospital and Research Center, Mumbai. And at present is the president of Neonatology Forum, Mumbai. So we welcome Rahul Verma, sir, to give his talk. Thank you, sir.
Thank you so very much. Kind of you. I think the first lecture was extremely valuable because that makes subsequent lectures easier for us, I guess. Okay, so without wasting any more time, and I'm hoping to finish it much before so that we remain in time. Today we discuss clinical evaluation of renal and urinary tract disease in a newborn. You can see my slide, right?
Yes.
Yeah, perfect.
Yeah, the moving slides, no issues. Everything clear, all good.
Good. So basically, you know, when we are introduced to a baby, a newborn, or parents before birth for any renal issues, there are a couple of situations where we are introduced to them. So one is antenatally suspected renal disease or a urinary tract anomaly or anomalies. So usually we get a reference antenatally. We talk to the parents if we are very clear what is happening, or if there's a suspicion, then we reassure them, and depending on the gestation, then we take it further for further studies, either repeat sonographies or for advanced imaging. The second instance where we would interact with such babies is immediately after birth, and there would be specific findings which then raise our antenna and make us believe that to delve into this further. Third point would be an incidental finding in the neonatal period. Just during routine rounds, you're looking for something else and you find something else which is related to the kidneys and the system. The fourth would be while treating such a baby, there would be clinical scenarios which suggest renal or urinary tract tissue issues coming up. And lastly, unfortunately, in some instances, these are autopsy findings. When a baby has succumbed to multiple things and you either confirm or you actually diagnose a renal problem in them. So these are the clinical areas where we would interact with the baby. Now, we've already spoken about sonography and scans, but we do understand that now more and more pickup is occurring in the high-risk population, especially with the past history of perinatal demise or abortions or miscarriages. But still, when you go through literature, what you realize is actually the pickup for congenital renal anomalies confirmed is only 1% on the antenatal scans, 1% by clinical examination, and a huge amount, almost 10 times that on autopsy. So I think we still have a long way to go, and similar to probably and a general anomaly scan or a cardiac scan, which we have started now doing more and more effectively, we need to actually go and aggressively look out for high resolution images on sonography, especially fetal sonography. The idea of looking out for renal anomalies is that an early diagnosis would definitely help in preventing complications in the baby. So you may have incidental hypertension coming up, or you may have progressive obstruction and reflux uropathy coming up. You may delve with a UTI, a urinary infection, and urosepsis, which then retrospectively leads us to a diagnosis, and of course, prevent renal failure. So the idea of diagnosing early is so that we can intervene at particular times. We can ensure that we talk about optimal delivery times. We talk about, as we spoke about, fetal intervention. So a lot of things over there. And that's why I think our pickup rates, which are not necessarily operator dependent, it also depends on what anomaly we are dealing with. Multiple anomalies, many a times, when you have a heart anomaly, somehow, it goes to an ecologist, a cardiac interventional person, rather than to a regular sonologist who then tends to forget to look downstairs also. So a lot of things over there, and we see how these things come in. So as seen in the last lecture, we have sonography suspecting or diagnosing a disease, and then of course we go for serial scans. In some instances, we also go for MRIs if we're not clear or if we're looking for more than one anomaly at that time. So simple things like hydronephrosis, the AP diameter, as Dr. Suksham said, is the commonest thing. 5 and 10 millimeters is a very important set of numbers to remember in the second and third trimester. You may be able to notice urinary retention antenatally, kidney anatomy suggesting cystic kidneys, multicystic or polycystic. Urinary ascites has been picked up quite often. Absent kidneys, I mean, this is one of the few things which definitely raise the antenna. So there's not much you can do at that time, but I think the parents are much more informed on this than anyone else. Oligoamnios should make us suspect that there is something wrong, and the renal system is definitely one of the systems contributing to oligoamnios, and fetal hydrops as one of the causes. So that is why, once again, I emphasize that the scans are very important, because they help us in deciding any fetal procedure or interventions if available. They help us in deciding the timing of the delivery. So if at 34 weeks you find that there is too much progression, too much dilatation, or there's urinary ascites, you may want to deliver this baby out earlier as compared to a full term. And then, of course, you need to plan out a full multidisciplinary approach so that you bring about the best outcomes in such babies. So coming to clinical features, now that we finished the suspicion, they can range from absolutely nothing. The baby may look completely normal to the other extreme, which is something like a Potter syndrome. So renal agenesis with pulmonary hypoplasia, which is also known as Potter's syndrome, is something which is so characteristic that it would be very difficult to forget it, as Dr. Suksham said, Eagle-Barrett or prune belly syndrome. So you have two spectra. One is absolutely nothing on one end, and the other end is a full-fledged set of clinical criteria. So somewhere in between these two things, you may have a few other features which may help us in deciding clinically whether this baby needs to be screened, needs to be looked into for any renal anomaly. So some of them are dysmorphic features. So for example, if you have abnormal ears, low set ears, trisomy looking like baby, then obviously we need to rule out horseshoe-shaped kidneys later on. And it's very important that we do remember all this. Single umbilical artery, we'll talk a bit more in detail because this has been overrated. Hypospadiasis, so that is another thing. A distal hypospadias may be comfortable. Proximal hypospadias obviously merits other investigation. Known anorectal abnormalities, so whether it is cloaca, whether it is vesicorectal fistula, all of these things need to be seen, because we talk about the baby passing meconium, and many a times what happens is we realize that the nappy or the diaper is soiled, little realizing that the meconium is coming actually from the anterior part and not from the rectum itself. So all of these things have to be kept in mind. We need to be very vigilant in all this. Polythelia, that is supernumerary nipples, is another association with possible renal anomalies. As part of charge of Acteral or Vater, we have vertebral anomalies, we have esophageal atresia. So all of these, where you confirm one midline anomaly, it is always a good idea to rule out other midline anomalies, renal being definitely part of that system. So coming to single umbilical artery, as a resident, I always used to rush, I found one artery, and immediately we would try to go for scans or look for other things. And when I went through literature, it was very surprising that the incidence of single umbilical artery ranges to about 4%, of which 2 to 20% of babies known to have single umbilical arteries have some renal issues. So that's a wide range. 20% was in Dr. Tonse's collection. 2% was in 2020, I forget the author. So it consists of either mild hydronephrosis or a possible subpelvic stenosis. Most of these were very small issues. The problem was that once you tell the parent that you would like to get a detailed sonogram done at least as a baseline because your baby has a single umbilical artery, always upsets them. So looking across, it seems as if, unless there are other additional risk factors, the current data would not justify going for extensive urologic studies in any form in asymptomatic babies having a single umbilical artery. So we need not rush in and do sonographies unnecessarily unless we have other associated malformation, or antenatally we have found that there are some other suspicious renal anomalies to be thought of. Hypospadias is something which you see quite commonly at birth unless you do not examine the genitalia. So that is one thing. 70% of these are distal, that means coronal and earlier, meatal, submeatal also. 30% are proximal, and these 30% are the ones which we need to be careful about. So penoscrotal hypospadias is known to be associated with ambiguous genitalia also and with renal anomalies. And the idea is that many of these hypospadiases are associated with recurrent urinary tract infection. So besides correcting it to prevent infections and ensuring that you've not missed out ambiguous genitalia, cosmesis then becomes very important. And it has to be done appropriately. Otherwise, it's not only the patient, but the guy standing next to the patient also who can get affected by poorly corrected hypospadiasis. So that is something we need to be very careful about. Polythelia, as I mentioned earlier on, extra nipple, it is associated with many a times obstructive abnormalities of the kidney or the renal collecting system. There may be an associated renal agenesis, later on renal cell carcinoma, or supernumerary small floating kidneys. So polythelia is something which I think we need to be very careful about, and it is worthwhile doing a screening sonography in such babies because we may be able to pick up something which is not very obvious at birth. Coming to the next clinical feature, which would be a palpable mass or a distended abdomen. So if you have a lateral, any unilateral or bilateral abdominal mass palpable, there is a chance that it might be polycystic kidneys because even those kidneys are quite bulky. It could be hydronephrosis, which has not been picked up on a sonography, primarily because no sonography has been done in the last 6 months for such mothers. Or it may be a tumor which is sitting somewhere in the midline or on top of the kidneys. The swelling could be suprapubic also, which could mean that we have missed out posterior urethral valves, which has brought about strong contractile suprapubic swelling, trabeculation of the bladder, or it could be a collapsed bladder because of urinary ascites. So ascites or abdominal distension lower down is important because then we start looking for things like urinary ascites and anasarca as part of renal disease. Already spoken, I think Dr. Suksham has already spoken about renal cystic disease, as we know that it's autosomal recessive or autosomal dominant. The difference being is that autosomal recessive actually can be seen very nicely even in the neonatal period, and the autosomal dominant sometimes initially may get missed, and of course later on when we scan the other organs we are able to pick up the cysts in the other organs also. Autosomal recessive obviously is lethal because many a times it is associated with pulmonary hypoplasia, or both the cystic kidney diseases may be associated with hypertension, which is an incidental finding. Many a times we just feel that the baby is crying excessively, that's why transiently the baby has hypertension, but on repetitive measurements we do find that the blood pressures are definitely above the 95th centile for that age and weight, or gestation and weight. And then of course we would start having some findings on the blood renal parameters like bicarb, creatinine, BUN. So this is something which I think we need to be very careful about. Outcomes, obviously the dominant one has a late onset, so probably a slightly better outcome. The autosomal recessive has got a bad outcome. So coming to other clinical findings, edema. So most of the premature babies are edematous. You by mistake infuse extra IV fluids, the baby becomes edematous. You have a baby in heart failure, the baby becomes edematous. Or if the baby is in renal failure or has a renal anomaly, the baby becomes edematous. So that is something we need to ensure, that if you do not have an obvious cause for edema, no anemia, no severe prematurity, no extra fluids, no heart issues, no liver issues, then obviously you need to rule out renal issues in such babies. Hypertension, as I mentioned, you have a nomogram available for gestation and day of life, and I think we need to measure. The problem is most of us measure blood pressure unless the baby is very sick. We measure by oscillometric method, which may not be accurate. As a matter of fact, many a times with coact of aorta, you will still have a normal blood pressure in the lower limb by oscillometric method. So there are fallacies to this, but repetitive measurements may ultimately bring about, and here we are looking at something which is very obvious, and obviously such babies merit further evaluation. You may have excessive weight loss. So this happens usually because the baby keeps on vomiting or may not be maintaining properly on oral feeds, and that's why you will have, too early to say, but something similar to a failure to thrive. These babies merit renal parameters to be examined as well as other parameters. Anuria, oliguria is something which is very obvious. For example, if you have renal agenesis, the baby will not pass urine at all. Not gaining weight is another correlation with renal insufficiency. So these are the other clinical findings we need to definitely focus upon. And if you cannot explain them on any one etiology or association, then definitely need to start widening the web and look out for renal anomalies too. Abdominal wall defects is very obvious. This is prune belly. And I don't think once you've seen a prune belly, you'll ever miss it. Pretty bad, actually. Very few survivors of this. It's a mess. So you need to look out for urinary infections, and then, of course, try to treat the other associated malformation. Extrophy of bladder is also very obvious, and so that is something which obviously will require evaluation and, if required, surgical intervention. Cloaca. So that is one of the things. Cloacal extrophy is easy, but just having a cloaca might be a problem. So all of these are some being very obvious, some not being so obvious. But these are the things on clinical examination which will definitely give us the diagnosis. We spoke about posterior urethral valves and the antenatal diagnosis of the same. After birth, if you have missed out PU valves, you may have a palpable bladder, you may have difficulty in passing urine, a poor stream, but quite often you may have a baby who actually passes urine regularly. So then it becomes a challenge. It's only because of either a ruptured bladder with urinary ascites or urinary tract infection, which then further gets examined, or a repetitive UTI, which then the baby comes back as an infant, and then you realize that actually there is posterior urethral valve which needs to be sorted out. The back pressure changes because of this can be quite alarming and can lead to irreversible damage to the kidneys. Hence, PU valves should be looked out for once you have any of these clinical features or an antenatal suspicion of the same. Horseshoe kidneys, I think, are also important. We've had 2 of them being diagnosed antenatally at our hospital. And we took it further. One of them was obviously a Down syndrome. The other one did not have any such associated anomaly. But many a times it can be picked up antenatally. You may have associated vesico-ureteric reflux. So a baby may have urinary tract infections, and you will have other associated, if it's part of a syndrome like Down's, Turner's, Patau, or Edwards, then you will have other features. Or if it's non-chromosomal but still syndromic, then you can have something like Ellis-Van-Creveld, Fanconi's, Kabuki, Pallister-Hall syndrome, and of course, Vater and Vacteral. So this again becomes something you may sometimes be able to palpate the kidneys, not anteriorly, but laterally, which look a bit big, and they may not be up in their position. They actually would be a bit lower down towards the pelvis. NICU care is not without its complications. And this is one of the issues which we definitely want to look out is acute kidney injury, whether it is because of fluid imbalance, whether it is because of birth asphyxia or hypoxia at the time of birth, whether it is part of the drugs that we give. Any of these can lead to acute kidney injury or the inherent kidney dysfunction or hypoplasia itself associated from birth, which can ultimately culminate into acute kidney injury. So oliguria, hematuria, proteinuria, edema, hypertension, cardiac arrhythmias, all of this gives us some inkling. Monitoring of babies who are especially on antibiotics, on TPN, on fluid restrictions with PDA, being treated for PDA, I think all of them merit some biochemical monitoring before we wait to see the signs and symptoms of acute kidney injury. The reason I put congenital nephrotic syndrome is because sometimes it can be a differential diagnosis for hydrops. And it may be secondary to congenital infections. Now, syphilis has reared its head. Congenital syphilis has reared its head again in the US, and I think we need to be aware of that. So that's why I included that this may be secondary to an intrauterine infection. The Finnish type obviously is the more common one, and it's autosomal recessive. The presentation is a hydropic or an anasarcus baby at birth. Another issue which we do see, and that is oliguria, and if you have a baby who's had a perinatal hypoxic event or an established HIE, then we need to look out for SIDH. So decreased urine output with hyponatremia, but a normal urinary sodium definitely points out towards SIDH. Very easy. We do these multisticks in preterm babies at least once a day. I think someone will talk about multisticks later on. But bedside monitoring, once you have clinical features, becomes important for us. And since bedside monitoring is part of the clinical rounds, I have put up these slides. So having an intake output chart, vital parameters, blood pressure measurement more than once if required, especially when the baby is calm. Never believe the first blood pressure. Keep the cuff on, wait for 10 to 15 minutes, repeat a blood pressure. If required, take a 4-limb blood pressure. But do make sure that your blood pressure is accurate. Pulse oximeter is very good. Tachypnea, oxygen requirement, respiratory distress, respiratory embarrassment may suggest fluid overload or pulmonary hypoplasia. Multisticks gives us a lot of things, whether it's on the first day of life, whether it's on the last day in the neonatal period or even in infancy, because it gives you so many parameters which you can evaluate and then take it further. Point of care becomes important for us. I've included in our clinical monitoring because it requires only 0.16 ml of blood to give me multiple parameters like blood gas, electrolytes, lactate levels, BUN, creatinine, hemoglobin, PCV. So all of this can be done with just around 0.16 ml of blood. So for that reason, it becomes a very, very valuable bedside. You don't have to take the absolute values, but having progressive values, that means monitoring it across and taking serial values becomes very important in babies, especially if they're very sick or whether they're on TPN or on the ventilator. So to conclude, there are many renal anomalies which are picked up antenatally. Our idea is to define the anomaly, get a plan ready, make sure you have a good multidisciplinary approach, and try to coordinate with the obstetrician to give an ideal time of birth. If required, in whichever institute where they're doing antenatal or fetal interventions, then plan that out too. That becomes very important. Careful examination of the newborn becomes very important so that we may pick up any associated signs. On their own may not be important, but a constellation of these may suggest renal anomalies. When we treat very small babies, then we also need to make sure that we monitor for, prevent, anticipate, and treat acute kidney injury in the NICU. Once again, an emphasis on multidisciplinary approach is so very important for us. And a follow-up of these babies would definitely make us understand our current treatment profile and the future of these babies. Thank you.
Thank you very much, sir. Thanks for your lucid talk. Now we move on our next session.
There are no questions. Are there any questions in the chat box anywhere?
That we will take.
No questions are at present.
No question
Okay.
at present, sir.
Thanks.
Okay, sir. So friends, among neonates and young infants presenting to emergency department with fever, the rate of urinary tract infection is almost 10 to 20%. The main cause of urinary tract infection in neonate is bacteremia and congenital anomalies. The upper urinary tract infection may lead to urinary renal scarring and chronic kidney disease. So neonate with UTI should be evaluated for associated systemic infection and anatomic or functional abnormalities of the kidney. So now we move on our next session, and that is from Dr. Tanushree Sahoo regarding diagnosis and imaging of neonatal UTIs. First, I would like to introduce Madam. Dr. Tanushree Madam is a assistant professor of neonatology. She has done MD Pediatrics from JIPMER and DM Neonatology from AIMS Delhi. She has published more than 50 publications in Neonatal International Journal and also contributed as an author in book chapter in 15 books. So with this much of introduction, I would like to give the mic.
Me this wonderful opportunity, and I thank Gujarat NNF also for giving me this opportunity. Am I audible? I want to share my screen.
We are seeing your slides. Oh, you need to share your screen.
Yeah. Just I think it is now.
You are audible, but can you share or you can't share? It's not allowing you.
I have already shared my screen.
Divyang, can you unshare, because I think we are seeing
actually a slide of Divyang. I'm just stopping the.
I have already shared my screen.
Yeah, now it's visible.
Okay. Okay, so after two excellent talks by Dr. Suksham and Dr. Rahul, my talk takes all the audience to a entirely different topic, that is neonatal UTI. And some of the management issues in neonatal UTI has already been covered in brief by my previous speaker. So let us move to that. So actually, neonatal, before discussing, I would like to discuss one case we recently managed in our ICU. This is our ICU is partly inborn and partly outborn. It takes care of the outborn babies. One day we received a 6-day-old male child who was born by normal vaginal delivery at 38 weeks gestation in an outside hospital with antenatal details not available, and baby was 3.8 birth weight, and he presented to our casualty with history of poor feeding, vomiting, and fever. And there is history of poor urinary stream that was reported since birth. It was reported by parents. So we did thinking it as a urosepsis and late onset sepsis. We did a sepsis screening which was strongly positive. And then on routine urine examination, we found there is a frank spouse was present, and urine culture sensitivity grew Enterobacter, which was sensitive to ciprofloxacin. And we also did a simultaneous ultrasound KUB, which revealed there is grossly bilateral hydronephrosis as well as thickened bladder wall. So probable diagnosis being posterior urethral valve. So after 14 days of IV antibiotic, finally the urosepsis was resolved, and then our surgeons took up the child for doing micturating cystourethrogram, which showed bilateral grade 5 BUR with posterior urethral valve. So ultimately, the child underwent a cystoscopic fulguration of posterior urethral valve on day 25. But unfortunately, he had again another urosepsis while in hospital in the post-surgical period, and that this time the culture had grew E. coli, which was sensitive to meropenem. So second course was adequately treated with meropenem for 14 days. Then the child was ultimately discharged on cephalexin prophylaxis. So why I am discussing this case, just to apprise my audiences that In many times, the neonatal UTI is not just simple UTI as we used to find in infants and older children. Most of the times, it is associated with upper urinary tract infection in form of pyelonephritis, and many times it is complicated. In our case, the child was lethargic, there is poor feeding, and it is complicated. Third, many times and most of the times in neonatal UTI, we have to be very careful to rule out congenital anomaly of kidney, urinary, and bladder. So with this, just let me focus what are the challenges in neonatal UTI as compared to elder infants. So as we know, most confusing part is that there is no specific guideline that exists for treating specifically about neonates. Despite we are having so much guidelines for other management like neonatal sepsis, breastfeeding, or neonatal jaundice, there is no specific neonate specific guideline for managing UTI. So before this presentation was given, I searched all the possible sources. I consulted my nephrology friends. So everybody, then I found out that whatever guideline is available from the AAP, American Academy of Pediatrics, or NICE UK guideline, even in our Urology Society of India, or IAP, Indian Pediatrics STG, the standard protocol guidelines, which was released just 1 month before in the this month only in the Pedicon. Everybody is focusing at least from 2 to 24 months, or some of them are focusing less than 1 year young infants, and NICE guidelines specifically saying 16 years. So that in absence of any existing guideline, the management of UTI is little bit is subjected to the expert opinion, and it is based on center to, there is lot of variation in management based on center to center. And unlike older children, most of them I have already discussed, they usually present with febrile UTI and pyelonephritis, and many of them are associated with congenital anomaly of kidney, urinary, and bladder. So I am not covering here vesico-ureteral reflux because its management itself will take another hour. So I am not covering it here. So in my presentation, I will be covering briefly the epidemiology of UTI in term and preterm infants. What are the microbiology, its pathogenesis, what are the host factors responsible, what is the clinical manifestation, and what is the investigations and treatments possible in briefly. So if we discuss the epidemiology UTI, one meta-analysis has suggested that prevalence of UTI is variable as per the age, gender, race, and circumcision status in male infants. And typically in children, boys are less prone to have UTI. Overall group is 2%, and girls are 7% at risk of having UTI. But this this female predominance is typically beyond neonatal period. In neonate, boys are mostly UTI incidence is more common in term neonate as compared to girls, and most of these are associated with underlying congenital anomalies of urinary tract. So coming to, it is not moving my slide. Okay, so several studies have demonstrated in the term infants, the overall incidence is varying from 10 to 20%, while in preterm infants, it can be varying from 8 to 13%. And more premature is the baby, more is the chance of having UTI. And in microbiology, the UTI, the epidemiology, microbiology in term infants is not different from the other older children. E. coli being more common and around 70 to 80%, while in other organisms like Klebsiella, Proteus, and Enterobacter can be other organisms. While in preterms, apart from E. coli, some other organisms like Cons, Klebsiella, and especially if there is prolonged hospitalization, Candida UTI is also in preterm infants. It's common. And as I have already described some of the host factors that is responsible for UTI, male infants, especially in neonatal period, are more risk for having UTI, uncircumscribed male, circumcised male, and prematurity itself is a risk factor because of several factors like prolonged hospitalization and catheterizations, underlying illness, all those things. And kidney urinary tract, all type of kidney urinary tract anomalies starting from VUR, hydronephrosis, PUV, pelvic ureteric junction anomalies, urethra, and pelvic ureteric junction anomalies. All these things are can lead to UTI in neonates. And when to suspect, as we know, initial 48 hours UTI is not common, so it is not a common practice to evaluate for UTI in a child who has presented as early onset sepsis. But in late onset sepsis, the incidence of UTI can be variable from 5 to 10% cases. So in term infants, if any child beyond 48 hours presents with fever, in the OPD it presents with poor weight gain, and typically there is prolonged late onset jaundice, prolonged persistent jaundice, or conjugated jaundice. In OPD, we should always evaluate to rule out UTI. And any child who is presenting excessive lethargy, vomiting, loose stools, and sometimes children can present with features of adrenaline crisis, especially those who are in having urosepsis with underlying congenital anomaly of kidney urinary tract. And in preterm infants, apart from these clinical features, some other clinical features like apnea, bradycardia, tachypnea, hypoxemia, abdominal distension, or NEC-like features also sometimes will suggest us to rule out UTI. And always in late onset sepsis, other differential diagnosis of UTI would be systemic sepsis, meningitis, and in IEM, inborn error of metabolism. So this classification of UTI, which is applicable for older children, like as based on site, it can be lower urinary tract infections, simple cystitis or pyelonephritis, or symptom-wise, it can be asymptomatic bacteriuria or symptomatic UTI, or complicating factor-wise, it can be uncomplicated UTI or complicated UTI. But unfortunately, most of the neonatal UTIs are pyelonephritis. They are symptomatic, and they are most of the times it is complicated UTI. That is why we should be very prompt in managing neonatal UTI. And in pathogenesis also, there is some salient changes as compared to the term, as compared to older children. And as I have already told, in most of the UTI in term infants, the ascending infections are ascending infections. Although they are ascending infections, but they are typically have pyelonephritis more common as compared to cystitis, while in preterm infants, most of the time it is hematogenous spread, means from bloodstream infection that can cause UTI. And as for any kidney urinary tract anomaly or any kidney problem, so typical diagnosis of UTI should have high index of suspicion followed by some basic laboratory diagnosis. Routinely what we do is urine analysis. For that we send urine routine and as well as urine microscopy and urine culture. Then ultrasound KUB for looking for any congenital anomaly of kidney urinary tract bladder. Then voiding cystourethrogram, renal dynamic scan. And depending on clinical features of baby, all neonates with presenting late onset sepsis should undergo a sepsis screening. However, CSF analysis for UTI is not recommended, and some studies have suggested 1 to 2% of all late onset sepsis might have underlying 1 to 2% of all neonates with culture proven UTI are likely to have underlying CSF meningitis. So hence CSF analysis should be not be done routinely, but it can be directed one-to-one basis depending on clinical features like which are suggestive of CNS involvement, like seizure, bulge fontanelli, or altered sensorium. Then we should do a CSF. As such, CSF analysis is not warranted in all cases of neonatal UTI. So typically these are the recommended methods of urine sample collection in for UTI in children: urinary bag or clean catch technique, and voiding stimulation, in which we just this is also known as quick wee technique, in which typically we have to wipe with a cold saline patch and the suprapubic area, and the child will pass urine after the stimulation. And these initially three are not routinely recommended for the neonatal urine sample collection. What we do most of the times in our ICUs and hospitals are clean, fresh catheterization followed by urine collection. Second, the best gold standard is suprapubic urinary aspiration. Though suprapubic urine aspiration is a traumatic procedure, but with invent of and availability of bedside ultrasound, it can be easily done ultrasound guided way in the NICUs. And for the and there are nice videos. Those who are interested, they can see the NEJM site. There is a nice video available in the suprapubic aspiration and collection of urinary sample. So interested people can go through it, and if any doubt, they can ask in the chat box. So coming to urine routine microscopy, ideally it has to be seen by our own residents. But if you're sending to microbiology, then it has to be freshly collected, and typically it should be examined within 4 hours of voiding, and it has to be centrifuged, and then we have to see at least 10 presence of 10 pus cells in a high power field is enough. So how we see in the high power field, we will see WBCs as well as sometimes bacteria. So presence of bacteria says bacteriuria, while presence of WBCs either more than 10 in uncentrifuged sample or more than 5 in centrifuged sample says significant leukocyturia. So both are suggestive of UTI. And other screening tests that has been already described by Dr. Rahul. So this can be used like leukocyte esterase, nitric positive, and microscopic leukocyte esterase or nitric test positive. So the sensitivity is variable. Combination of leukocyte esterase and nitrate positivity will increase the sensitivity up to 93%. And if you combine all three, like microscope as well as nitrite and leukocyte esterase, the sensitivity will increase up to almost 100%. So it can be used as a bedside screening test. And as we know, gold standard urine culture is the gold standard for UTI. And there are certain difference. This box I have taken from the IAP guideline, IAP neonatal IAP guideline for management of UTI for younger infants, in which it is written suprapubic aspiration of any number of pathogens is suggestive of UTI, while urethral catheterization sample, it should be 5 into 10 to the power 4. But however, there might be some change, because in neonates they void frequently. So that amount of significant bacteriuria might not be possible even in neonates. Low counts, even up to 1000 colony counts per ml, colony forming units per ml is also taken as significant bacteriuria.
3 more minutes.
Yes. And asymptomatic bacteriuria, most of the times it is because of E. coli, and generally in neonates, asymptomatic bacteriuria also needs to be treated because it has some significance. And now coming to investigations, unlike the young infants, in which we have to just decide in which group needs detailed investigations, which group doesn't require. So as a rule of thumb, all neonatal UTI needs to be investigated in detail, because as high as 40% of them can have abnormalities in ultrasound. And even if ultrasound is normal, sometimes they will have vesicoureteric reflux, VUR, in your micturating cystourethrogram. So as a rule of thumb, all neonate who is having culture positive sepsis, first episode of culture positive sepsis, should be evaluated with ultrasonography in acute stage, followed by MCU or micturating cystourethrogram after the UTI is resolved. And DMSA scan and other renal dynamic scan has to be done ideally 3 to 6 months following treatment of UTI. This is for checking for the scarring and functionality of kidney. So we can see in these images I am showing. So ultrasound has to be carried out in all first episode of culture positive UTI, DMS scan for all babies after 4 to 6 months of resolution of UTI, and in MCU. We have to do, it is actually invasive procedure. We need help of surgeons, and when there is active urosepsis, it should not be done, because there is always chance of having flaring of infection and pyelonephritis. So we always, surgeons here will always wait till the urine becomes sterile and culture and the baby has been adequately treated for UTI, then only we will take. And it has a risk of always a risk of exposure of radiation. But nevertheless, it is a necessary test for neonatal UTI evaluation, because sometimes sometimes ultrasound might be normal, while only reflux will be detected in the MCU. So this one already I have told. So this is the urologic evaluation that has to be done in fast UTI as per the Indian Academy of Pediatrics 2021 guideline, which has been amended recently in the 2022 standard treatment protocols. So this one already I have described. And second thing, so this is another guideline that has also been recently published in 2019. It also says the same. First episode of UTI needs to be evaluated by ultrasound KUB, and whether it is normal or abnormal, it has to be followed by micturating cystourethrogram. And some guidelines say then after micturating cystourethrogram, it needs to be we have to evaluate with a DMS scan after 6 months. So here there is a little bit confusion, because sometimes some of the guidelines are saying we have to do with a recurrent UTI by a DMS scan, but some of the guidelines are saying that we have to all neonates with culture positive UTI, we have to evaluate initially ultrasound followed by MCU, then DMS scanning. So what are the after the culture we have done, we should not wait till the culture report is coming. So if we are having high index of suspicion, we should start with empirical therapy based on your previous unit data, what are the organisms are coming in your unit and what is their sensitivity pattern. And once the culture report has been obtained, then obviously depending on the sensitivity, the antibiotics can always be always can be changed or downgraded as per the culture report. And these are the typical antibiotics which are used for, there is no question of oral initially in neonatal UTI. So we will start with parenteral UTI. Parenteral antibiotics, typically amikacin, gentamicin, or third generation cephalosporin, sometimes ciprofloxacin and piperacillin tazobactam has been administered in neonates for UTI. And the dose this is the dose I have taken from the standard treatment protocol of IAP 2022. This is the dose that is given for pediatric use. And for neonates, we like any other antibiotics, we always follow the neonatal dose adjustment as per the RFT, renal function test report, and Neofax book. So once the UTI, regarding the duration, there is still a confusion. So if you come to management of febrile UTI, so we can see this thing already I have told. Any child who is having neonatal UTI and he is looking sick, we have to start with IV antibiotic. At least give for initially 2 to 3 days. And then if there is response, we can consider switching it to oral to complete total duration 10 to 14 days. Or some of the units, even in the Western units, they are completing the entire course of 10 to 14 days by IV route. In our unit also, as per our unit policy, we are completing the entire duration of antibiotics in neonatal UTI by IV route only. So the optimal duration and route is still not clear in neonatal UTI. And as I said, I am not covering in details regarding vesicoureteric reflux, but if there are any kind of vesicoureteric reflux, then we have to give antibiotic prophylaxis for grade 1 and 2 till 1 year of age, and beyond that we have to continue till 5 years of age or till the or beyond if there is continued bladder bowel dysfunction. And in neonatal period, due to there is risk of having G6PD deficiency related bleeding and all problems, so we don't administer co-trimoxazole and nitrofurantoin. Instead, the common antibiotic prophylaxis we use in neonatal period is cephalexin group, and the dose is 10 milligram per kg per day. So my take-home message for neonatal UTI will be: UTI are little uncommon in initial 48 hours, and symptoms are usually variable in first few days of life. Hence, it requires high clinical suspicion for diagnosis. And diagnosis should always be based on culture of the organism from freshly catheterized urine sample or preferably suprapubic urine aspiration. And E. coli remains most common organism in both term and preterm babies. And when awaiting the urine culture report, empirically you have to start antibiotic therapy based on the culture sensitivity pattern in your unit based on your previous sepsis data. And the optimal duration for culture positive UTI and the route for giving optimal antibiotic in neonatal UTI is still not clear. The practice varies from different units from 10 to 14 days. And all culture positive UTI should undergo evaluation both with ultrasound KUB as well as micturating cystourethrogram. And antibiotic prophylaxis might be required while awaiting MCU if there is some abnormalities in ultrasonography. Or okay, so these are my suggested reading. Thank you.
Thank you very much, madam. Thanks for your lucid and interesting talk on UTI imaging and diagnosis management. Now we have a panel discussion that is on neonatal acute kidney injury. We have one moderator and 3 panelists for that. I would like to introduce our moderator first, and then she will ma'am, please let me share the screen first. Uma madam.
Jain, you can introduce her.
Okay. Okay. Dr. Uma madam is a professor and senior consultant at Department of Neonatology, Sri Ramchandra Medical College and Research Institute. She is honored as a recognized as a research ambassador in the same institute, and she has won so many awards and in publication. Best Poster Innovation Award by Neonatal NNF in 2016, and she remains as the best outgoing student and got a 5 gold medal during her MBBS. So she is very much academician, I would like to say, and now she is going to moderate the session for next 4:45 to 5:30 till 5:30. And now I would like to switch over the mics to Dr. Uma madam, and she will introduce her panelists for the next session. Thank you, madam.
Good evening, all. I would like to thank the Gujarat NNF for inviting me to moderate this session on acute AKI.
I would like to just interrupt for a moment. I would like to share that we are very grateful to Dr. Uma for coming in as a moderator at the last minute. So we had another moderator, as many of you would know, but he had an emergency today, and Dr. Uma stepped in, and we're very thankful to her for making this a very interesting discussion. Sorry, ma'am. Go ahead. Please go ahead.
Thank you, sir. Thank you for the opportunity, and I would like to introduce my panelists today for the panel on acute AKI. So first, I would like to introduce Dr. Purva Dikshit Kohia. So she is working presently as associate professor in Gandhi Medical College, Bhopal, and she is a gold medalist in MD Pediatrics. She is very much interested in medical education, and she has done advanced course in it, and also she had been a great publisher, reviewer, and national faculty for many courses, and has been a facilitator for many training programs. So would be happy to have her. And we have pediatric nephrologist, Dr. Fahim Shah. So I think we are always talking about collaboration. So without you, this panel would be incomplete, sir. So it's a great pleasure to introduce you to the audience. So his he runs Child's Kidney Care Center in Surat. And he has been a faculty in many national, state, and state conferences for both pediatrics as well as for pediatric nephrology. And he has been the organizing secretary of West Zone Pericon. And his areas of interest includes renal replacement therapy. And Dr. Vishnu Mohan, I think he does not need introduction to the audience, so he's very well known. He has, from whatever it is written here, the national coordinator for IAP Perinatology module, member secretary for IAP's SDG group, zonal coordinator, state academic coordinator previously. So the list adds on. So I don't think Dr. Vishnu needs any introduction. He's a consultant neonatologist in Aster, MEMS in Calicut. Panelists, are we all ready? So
yes, madam, go ahead. Yes, you can just shoot.
Thank you. So we, the importance of neonatal AKI can be very well understood by having a CME in neonatal nephrology. So neonatal AKI is quite common and it is independently associated with mortality and morbidity. So there has been some progress in potential preventive strategies, and there has been recent concepts on crosstalks between kidneys and other organs. So like I want to bring out all these points in the panel. So let me take you through a scenario here. 26-weeker primary ICSI conception, PPRO in preterm onset of labor, did not have much time to cover for steroids, just one dose given and transferred to tertiary care center where emergency LSCS was done. Baby spontaneously took breath at birth, cord clamped at around 30 to 45 seconds, started on delivery room CPAP. It's a boy baby and weighing 960 grams and transported in a transport incubator. I think this particular scenario is quite common to any neonatologist. So in NICU was started on CPAP for RDS, started on piperacillin and amikacin, and intubated, given surfactant by ensure technique, UAL, UVL access, given a loading dose of caffeine followed by maintenance. However, because of the roller coaster ride which any preterm baby there was increasing FiO2 by 4 hours, and the ABG started showing hypercarbia, baby became hypotensive, was ventilated and had a pneumothorax as well. So while this roller coaster ride is going on, I want you to take your eyes away from the routine respiratory path and serious cardiovascular path and want you to focus on the renal parameters here. This particular baby had a serum creatinine of 0.8 and which at 36 hours, which rose to 1.2 milligram per DL at 48 hours. Can I ask Dr. Purva, does this neonate have AKI, acute kidney injury? So how do we define it? We are hearing varying definitions like rifle, kidgo, akin. So which one should we choose? So Dr. Purva?
Yeah, good evening. So yes, by this scenario and with the serum creatinine values, we will be thinking that this preterm neonate who is extremely low birth weight can have AKI, and we do have lots of definitions. So what is a simple general definition of AKI? It is defined as an abrupt decline in renal function that results in derangement of fluid balance, electrolytes, and waste products. We have definitions from kidney diseases improving global outcome, which is the full form of KDIGO, the rifle, and akin. So let us see how these different these definitions varies according to the serum creatinine criteria, and also they have the criteria of urine output. But the most important thing is whether these definitions which we have been listening, like KIDCO or the rifle or the akin, are they suitable for a neonate? Because these are already validated. They are all validated for the pediatric and the adult age groups, but whether these are validated in the neonatal age group. So we do have this definition, which is modified for neonates, which is the kidney disease improving global outcome definition, and it is the most accepted definition, and it is also validated in a multicentric study, which is Awaken. And this study this study has been done in Australia, Canada, and also India was also the part of the study. So this study becomes very important for us, as India was the part of the study, and also KidGo criteria have the emphasis on oliguria. So what is the criteria? The modified neonatal KidGo criteria, we have the serum creatinine values, and we have to know what was the baseline values and what and how do it rise. Along with that, we have the urine output values. The one important thing here is they have changed one criteria. Previously, in also this KidGo criteria, they used to have the serum creatinine value of 4 milligram per deciliter for the stage 3, but now it has taken for the neonates, it has been modified to serum creatinine more than 2.5 milligram per deciliter, because that represents a GFR of less than 10 ml per minute as per the body surface area. And also the receipt of dialysis and is same as the other definition. So we take this definition for diagnosing AKI in a neonate as the most eligible and also researched definition for the neonates.
Thank you, Dr. Purva. You have kind of highlighted the importance of varying definitions and this baby fitting into a definition of AKI. Particularly, what other information do we need for the diagnosis, and which stage do you think this neonate will fall?
We do have two serum creatinine values for this baby. We can see that we have a urine output value also for the last 12 hours, which is 0.4 ml per kg per hour, and which is an oliguria as per this neonatal modified KidGo criteria. Here we see that the serum creatinine rises more than 0.3 milligram per deciliter within 48 hours, or a rise of 1.5 to 1.9 times of the reference creatinine value. Here the reference creatinine value will be the lowest creatinine value of that baby. So we do have in this case scenario, there was two creatinine values, and the one reference creatinine value was 0.2 milligram per deciliter, which rose to 1.2 milligram per deciliter. So this our child, our baby, has two criteria which are there in the modified KidGo definition. As per the urine output also, it is less than 0.5 ml per kg per hour in the last 12 hours. So this baby, our reference baby of which we are talking about, will be baby is having AKI.
Yeah, thank you, Dr. Purva. I think that that tells us the importance of surveillance of serum creatinine as such. Yes. So I think in the midst of all the roller coaster ride which preterm can potentially have, I think we should not be missing to look at it both in terms of urine output and serum creatinine. You have well kind of reiterated this fact. Thank you so much. And moving on, can I ask Dr. Vishnu, why preterms are particularly more prone for AKI? We know that neonatal AKI are as such common compared to any other group, and in particular preterm are more prone. And like, what are the clinical and lab parameters one have to monitor?
Thank you, madam. A very good evening to all. First of all, let me thank my dear friend Dr. Prashant, Somsekhar sir, and Team NNF Gujarat for the opportunity. So back to the question. So as the risk for AKI increases as the gestation decreases. So from literature, there's almost 18 to 40% incidence of AKI in very low birth weights and preterms of the admissions in our NICU. So mainly the reasons being the functional and developmental immaturity of the preterm kidney that affects the glomerular filtration, as well as the reduction in the concentration ability due to the loss of tubular function. And again, the large insensible water loss in these babies, relatively due to their relative larger body surface area to mass compared to term babies and older children. And again, another reason being the increased evaporative loss due to equipments like radiant warmers for the old generation phototherapy machines and all being used in our units. So these are, and all the more, two more risk factors, which includes the PDA, which is most commonly encountered one in prematurity, as well as a few of the nephrotoxic drugs which are unavoidable in our routine care. So these would be the risk factors that contributes for a higher incidence or risk of AKI in treatments. And coming to the lab and clinical as well as lab parameters. So definitely primarily and most importantly, we should have a review of always have a review of the medication charts in our day-to-day practice, and have a review for nephrotoxic drugs that we are in use, and again adjust the dosings according to the severity of the AKI in these babies. And into the physical examination, we need to have a regular and routine check of the volume status of the baby by monitoring the regular weight check, as well as a monitoring of the intake as well as the output of the fluids. So always, we all know volume loss is one of the most commonest causes for acute kidney injury, as well as fluid overload being the result of the insult. So coming to the labs, and again, as a routine, we need to have a close monitor of the vitals, including the blood pressure. And to the labs, looking to the labs, we need to have a check on the electrolytes. We commonly encounter with hyponatremia, hyperkalemia, metabolic acidosis, hyperphosphatemia, and hypocalcemia regularly in AKIs. And again, a regular check on the serum creatinine, urine analysis, regular routine evaluation for check on proteinuria, as well as few CAS, which can be leading factors or clues for diagnosis. And finally, renal ultrasound can be helpful to evaluate congenital renal dysplasias or urinary restrictions, and to rule out the renal vein thrombosis, a doctor can be helpful. So those are the parameters that we need to mainly look into clinically as well as laboratory.
Yeah, thank you, Dr. Vishnu, for telling us about the importance of clinical parameters. I think here weight, as we all know, weight of the baby is the criteria which we are going to use for the fluid overload, and weight of the nappy is the one which we are going to use for urine output. So I think that weigh the baby, weigh the nappy. So usually our nurses generally weigh like once in 3 hours the nappy. So even in the studies, maybe that was used as a surrogate marker. Not all the babies get catheterized. So thank you for bringing out all the important points. And back to you, any other risk score for to predict AKI? Like, can we predict, oh, this baby is going to go for AKI, or this baby is going to be spared?
Yeah. So I was just looking into a few evidences when. So there are a few indices that help in early identification and risk prediction. Mainly the renal angina index, as well as the furosemide stress test. So those are the two indices that we commonly use for prediction of AKIs. So the renal angina index being a scoring system derived from clinical risk factors as well as the signs of injury, where the risk factors are classified into 3, basically the moderate, high, and very high risk. Where the ICU admission is taken as an independent risk for the moderate risk, and intubation as well as inotrope use being taken as the very high risk, where they are given scores accordingly. And the injury score were signs of injury, like the fluid overload and effective creatinine clearance is being used. So a combination of score of compound score of risk score as well as injury score gives you the renal angina index, which is scored from 1 to 40. And it is published in the AWARE study, which helps us in predicting the risks of AKI in our ICUs. And again, another factor would be the furosemide stress test, where a single dose of furosemide challenge is given, and the urine output for the next 24 hours being monitored, which can again help us in predicting the AKI in these units.
Yeah, thank you. I think more has been done in the pediatric population, which we are planning. We are kind of inclined to extrapolate those information in neonatal, so that we are also benefited in knowing and predicting the renal injury. Can I ask Dr. Purva, like, what are the risk factors of AKI in this particular neonate?
Yes, so we have this neonate who is a preterm neonate and has born extremely low birth weight. Also, there are the child had RDS, and also we had started the child on piperacillin and amikacin. Amikacin is an aminoglycoside, and we all know that aminoglycosides are known to be nephrotoxic. So these are the along with these are the risk factors which we have in our case scenario, which we are running over here. But other risk factors are hypoxic ischemic encephalopathy, sepsis, dehydration, and congenital heart diseases. Congenital heart disease mainly also when the child is on a cardiopulmonary bypass. These are the more other risk factors which make a newborn prone to AKI.
Very true. I think like congenital heart disease, even otherwise like ECMO is also a very high risk area where the baby can go for AKI, and the fluid output is quite monitored very vigorously when they are on. So let me ask you again, could you name some medication which predispose to AKI, and how do medication predispose to AKI?
Yes, so medications which are routine of our NICUs, antimicrobials, which we are in a very daily use, like aminoglycosides, which is like the most commonly used drugs in the NICU. Then vancomycin, amphotericin B, acyclovir, intravenous immunoglobulins, and radiocontrast agents. These are some of the drugs which are nephrotoxic, and we know that with all these antimicrobials, especially the aminoglycosides, they have a direct toxic effect on the tubular epithelium through inhibition of lysosomal phospholipase, and this leads to the cell death. So aminoglycoside group is a very dangerous group for the kidneys, and also they are autotoxic. Again, vancomycin, which is a drug which is being used for neonatal sepsis. It causes oxidative cell damage of the proximal tubules. Amphotericin B, which is used as an antifungal, damage to tubules and causes vasoconstriction. Acyclovir, not a very commonly used drug in NICUs, but yes, is a drug of choice for the herpes simplex infection, which can occur in a neonate, and it causes intratubular deposition of crystals, and which leads to blockage of the tubules and thus vasoconstriction. Many times we do use IVIG in the neonates. There are some absolute indications. So it increases the solute load, mainly sucrose or maltose are used, are there in the IVIG injection. So here we should know that this causes the increased solute load and can lead to acute kidney injury. Radiocontrast can lead to hypoxic medullary damage. So these are some of the drugs and their mechanism of action through which AKI can occur in a neonate.
Thank you, Dr. Purva. I think you have well elucidated the pathophysiology in which these medications cause renal injury. I think we have to be following antibiotic stewardship, not only for the sepsis, but also for AKI prevention. And there is a baby ninja study where these medications were looked into very protocolized manner, and they could save some of the babies just by having a quality improvement initiative in these medications. So I think definitely this step one of all of us should remember. So again to Dr. Vishnu, so if you remember, like this particular neonate was started on caffeine, all of us wonder whether caffeine is a lung drug, whether it is a brain drug, or now are we going to call that as a kidney drug as well? So is there a role for caffeine in neonatal AKI? If so, like, is it protective? Dr. Vishnu.
Yeah, thank you, madam. So we all know the like wonderful effects or benefits of caffeine, like as you mentioned, for the lung as well as the brain. So now about the kidneys. Again, caffeine impacts the renal perfusion by inhibiting the adenosine-induced vasoconstriction. So looking into the evidence, there are two big trials, one with a sample size of around 675 neonates, and by Conady et al. Were 140 newborns were studied. The Awaken study, where every 4.3 newborns exposed to caffeine, 1 AKI was prevented. So from the evidence, definitely there was a lesser incidence of AKI as well as less oliguria and better fluid balance. So caffeine does help in neonatal AKI from whatever evidence is available.
Yeah, thank you, Dr. Vishnu. I think that number is quite impressive. Like for every 4.3 neonates exposed, 1 AKI is going to be prevented. Yes, it is very impressive. Maybe like there are like the same group of theophylline also tried in hypoxic ischemic encephalopathy and babies on cooling. There are studies which are coming up in those areas also. So maybe this are some of the medications which one have to look at the preventive stage. So I think we have kept Dr. Fagun quiet for a while. I think at this point, I want to ask him, is there any role for low-dose dopamine? Because we have been using it. Like during my residency, we used to put on some low-dose dopamine whenever there is the AKI setting in. And like, what about furosemide infusion? Is there any role for these medications at all in AKI? Dr. Fagun.
Yeah, thank you, madam. And at the outset, I would also like to thank Dr. Prashant and Dr. Somsekhar for giving me this opportunity. And well, I just feel an odd man out among the group of the neonatologists, but I do feel that when the management comes, I will be an important part of the discussion. Well, anyways, as you mentioned, madam, that in our undergraduate days, we talked a lot about using dopamine and also talked about using furosemide for the patients having an AKI. But one very important thing which we need to cater to and we need to understand is that basically both these drugs do increase the renal blood flow, and hence it can convert an oliguric renal failure into a non-oliguric renal failure. But however, it is very, very imperative to understand that it does not prevent AKI, nor does it alter the course of the disease. And most importantly, it doesn't obviate the need of a renal replacement therapy if in case it has to be instituted in any of the children. Nor is it used to reduce the frequency or the duration of the RRT. But having said that, there are some instances, especially in our group of the neonates, especially in a very low birth neonates, where this could be of the use. That is, we can exploit the conversion of the oliguric into a non-oliguric renal failure. Say, for example, this old neonate who is 900 grams might face some other problems like having an necrotizing enterocolitis, or might having a severe pulmonary compromise, in which putting a catheter into the abdomen and instilling the abdomen with fluid might lead to certain other complications. In addition to this, practically we might have these children with sepsis who might have severe bleeding tendencies, and again putting a catheter might lead to severe bleed. So practically speaking, there are some of the instances, a very small group of patients in which we might benefit by just conversion of a non-oliguric to an oliguric to a non-oliguric renal failure. And especially if the electrolytes and blood gases and other things are doing good, if the child is not uremic, then this would definitely help. But however, one has to exert caution that whenever we have the electrolytes going bizarre, or the blood gases going bizarre, or in the cases when we don't have a urine output, we cannot wait for the whole day, 24 hours for the urine output to occur by giving furosemide or dopamine. We just need to wait for a couple of hours, maybe 4 to 6 hours. And if we don't get a urine output, in that instance, we need to resort to a renal replacement therapy. So in a nutshell, we need to understand that furosemide, dopamine are not the drugs to prevent the AKI or treat AKI. Definitely in certain group of patients, we can use the drugs if it is possible to convert an oliguric or into a non-oliguric renal failure, given the conditions in which we preclude the use, or to put a catheter, or to put a PD catheter, especially in a abdomen in a small neonate.
Yeah, thank you, Dr. Fagun. That was quite useful. Can I get back to Dr. Purva? Like, so we know that this particular preterm had a possible pre-renal because of hypotension and other factors. What are the common causes of neonatal AKI?
Yes, so we have this, we divide this according to the pathophysiology. We have a pre-renal, a renal, or a post-renal cause, and what could be the pathophysiology in the pre-renal. So pre-renal AKI is the most commonly encountered AKI situation, where there will be a functional change without the actual renal damage. Here we will have a what could be the causes in the pre-renal AKI? There can occur a decreased intravascular volume, and then it will lead to a diminished renal blood flow. So what conditions can lead to decreased intravascular volume in a neonate? This could be because of a placental abruption, excessive gastrointestinal losses, and increased insensible losses, especially in the premature neonates, extremely low birth weight neonates with skin immaturity, or there could be an increased capillary permeability, which we see in sepsis, or there could be a decreased oncotic pressure because of the hypoalbuminemia. Also, this is could be a common finding in an extremely low birth weight newborn. And other causes which can occur, which can lead to a decreased renal blood flow, can also, because of directly impaired states of hypertension and also compromised cardiac output, there could be a abdominal compartment syndrome, which is generally a part of NEC, necrotizing enterocolitis, and the drugs. These drugs I am mentioning here separately, indomethacin and ACE inhibitors, because they could be the child could be prenatally exposed as these NSAIDs are given to the mother as tocolytics. They can cross the placenta and they can lead to decreased urinary blood flow, and also this can lead to pre-renal AKI in a neonate when it is being given to the mother. Apart from this, we use indomethacin for PDA closures also. So this could be during this, as our baby is a preterm baby, and yes, we had seen in the scenario there could be the baby can have PDA, and we could have done use indomethacin for PDA closure. So this can also lead to AKI. And ACE inhibitors, we all know, are known to cause AKI, whether prenatally exposed through mother or they have been used in the postnatal period. So then there could be a renal AKI, which we know as ATN, and in many studies it has been shown that this is like 10 to 11% of babies who have AKI can have acute tubular necrosis, and this can occur because of the functional change which has been occurring in the pre-renal AKI has not been adequately corrected, and then it can lead to true kidney damage. So renal AKI may also be due to vascular compromise, as may be seen in the bilateral renal vein thrombosis or renal artery thrombosis seen with umbilical artery catheter malposition and renal infarct. This can also occur. Both these things can occur in a very critical babies who are being taken care in the NICUs, where an umbilical artery catheter has been placed and it could be malpositioned. Also, we can have, this is the post-renal AKI. This is the least common, and many studies have quoted around 3% to 4% reasons for this. And what are the congenital causes? These could be a posterior urethral valve or a UPJ obstruction. Then there could be postnatal causes. This could be urethral strictures, which can occur because of like difficult catheterization or a fungal ball. So these can lead to post-renal AKI.
Yeah, thank you, Dr. Purva, for like elaborating on the causes. I think it could be multifaceted also, like one going in for, like we'll be thinking that it is pre-renal, then it could move on to renal. So in terms of sepsis, there could be secondary sepsis, and the same baby can even have post-renal. So well pointed out. So to Dr. Fagun, at this stage, like we are lying at stage 1 of AKI in this particular preterm. Could you outline the management?
So if we take into consideration the generalized form of management, we could divide into two parts. One is the conservative management, and one is the patients in whom we require a renal replacement therapy, or nowadays what is known as the renal supportive therapy. So as far as the management is concerned, the most important things which I've mentioned over here are the things which we need to cater to. And here the most important thing which will be detrimental to our outcome would be a good fluid balance. So the fluid balance is the most important thing which we take into consideration, followed by the electrolyte and acid-base balance, because this can be the silent killers in patients who are having AKI. Drugs, as already mentioned. In fact, I would like to stress upon the use of the drugs, because in adult population, it has been found that 14% of the cases of the AKI were because of the drugs. And in fact, 25% of the drugs which we use in our ICUs are having potential nephrotoxicity. So if we take into consideration the drugs, they are very, very important cause of the AKI in whatever age group we are considering. Again, important stress on the maintaining the nutrition, blood pressure is very, very imperative. And finally, the treatment of the underlying cause. So these are the facets which will be need to cater to when we are managing the case of a AKI. And as already mentioned, the fluid balance is very, very imperative because it is considered as an independent risk factor for the mortality. In fact, the AWARE study showed that above 5% of the fluid gain, every 1% rise in the fluid overload will increase the mortality by an odds ratio of around 6%. And in fact, increased fluid overload will itself is a risk factor for not only AKI, but also of the mechanical ventilation. And so in all our babies, right from the fluid resuscitation, especially when they are having a volume depletion to a maintenance of an optimization of the fluid balance to a resuscitation in case when the fluid overload has occurred by use of the diuretics or by doing the ultrafiltrate wherever necessary is very, very imperative.
Okay, so let us move on what happened to this particular baby. So neonate subsequently became anuric. The creatinine rose to 2.2 milligram per kg per DL, and ECG is showing tall T waves. Now, again, over to you, Dr. Fadul.
Yeah.
So how do you want to take this baby?
Yeah, so if you take into consideration the KDIGO guideline, which was mentioned earlier, the child is having anuria, the child is having creatinine almost about 2.2. So straight away, straight into the stage 3. And anyways, with these reports, you straight away need to go for a renal replacement therapy. But the thing which I will be worried upon is the potassium levels, which are very, very high, and it has led to the changes in your heart. So it is very, very imperative that when we try preparing for the renal replacement therapy, at the same point of time, we need to stabilize the heart. And I think everybody knows about the measures to stabilize the heart, which includes the use of calcium gluconate to prevent the arrhythmias, to the use of soda bicarb, nebulized salbutamol, glucose insulin drip, K-binders. I think we don't need to go details, but we need to stabilize the heart and we need to bring down the potassium levels to a level in which the heart is not affected much while we prepare for the renal replacement therapy. And then we move ahead with the renal replacement therapy. I think these two conditions are also very much missed upon when we deal with the patients who are having hypokalemia, neonatal AKI. One is the hyponatremia. And I think this is one of the conditions which is quite forgotten about. Hyponatremia in a patient with an AKI is always a dilutional hyponatremia. And most of the times you have a normal body sodium. So we can't waste time in giving fluids and correcting the sodium levels in the body. So in the conditions when the hyponatremia is very severe, it straight away becomes an indication when you need to go for a renal replacement therapy. And so do for the metabolic acidosis, which is absolutely common in the patients who are having an AKI, and especially in the patients who have all these sort of issues like hypertension, sepsis, or the pulmonary issues. And here also, if the acidosis is very severe, you can't go on pushing the bicarb, but it merits the need for a renal replacement therapy. So as far as the renal replacement therapy is concerned, the most important thing for the statement is that initiate the dialysis whenever you have the earliest sign. So don't wait or don't try to give yourself a time. Initiate the dialysis. You might need to stop earlier if the patient improves, but definitely if you delay, the chances of the morbidity and mortality are very, very high. And we don't have any optimum level for the renal function at which the dialysis is to be commenced. So we need to embark upon our clinical symptomatology as far as the and also the biochemical symptomatology. So the patients, as far as the clinical symptomatology is concerned, we need to look for uremia. That is, if the patient is having uremia or uremic encephalopathy, or the patients are having cardiac compromise, the low output states, GI bleeding, hypercatabolic states, or the patients having severe pulmonary edema or ARDS. And finally, in a small neonate like in this child, we need to create the space for IV medications, blood products, parental nutrition, etc., which all indicates that we need to create a significant amount of ultrafiltrate. And the biochemical indications are very straightforward. As we already mentioned, resistant hyperkalemia, severe symptomatic hyponatremia, and severe resistant metabolic acidosis.
10 more minutes, ma'am.
What are the options? What are the options available as such? Like we have peritoneal dialysis or CRRT. Like, what are the options for this particular baby as?
Yeah, actually, I think so we are left with very little options as far as the neonate is concerned. What we do have in our bag is basically peritoneal dialysis, which is readily available, doesn't require much technical expertise. Even the residents can put a catheter, and whatever catheter you are suitable with, you can put it. You don't need to go for very high tank of catheters or other catheters. Even a simple trocar cannula, which you put for an ICD, you can put inside and start instilling the fluid, peritoneal fluid, the PD fluid, and start dialyzing the child. Though it has some caveats, let's say, for example, in the patients with the NEC or intra-abdominal surgeries or patients with the abdominal wall defects, etc., all those listed over here, it might not be very much feasible. But in most of the patients, we will be able to go for a peritoneal dialysis, and this is absolutely imperative in patients with the neonatal AKI. Though we have some sophisticated therapies like continuous renal replacement therapy by this Prisma machine, but however, these therapies are designed mainly for the adults. I just had one children of around 4 or 5 kilos whom we dialyzed with the help of this machine. But otherwise, it has significant challenges, as I've mentioned, that there are significant loss of extracorporeal volumes, and this might lead to severe hypotension. You need to keep a very high blood flow rate. Again, the problems with the vascular access, because you don't get the size of the catheters to put into the neonate. And there is always a problem with the anticoagulation, especially with the sick neonates when you have a high APTT derangement or a low platelet. But however, you can create a very high ultrafiltrate very slowly. It enables a nutritional rehab and a good solute clearance, and definitely a good maintenance of acid-base balance and electrolytes. So wherever feasible, and if you have a technical expertise, you can always resort to a CRRT.
Yeah, thank you. That was very elaborated. I think regarding neonatal peritoneal dialysis, because of time, I will just conclude. We can use varying catheter, as was mentioned by Dr. Falgun. We often use pigtail catheters in our unit, and it is very useful. It does not get blocked because of multiple points. And Dr. Vishnu was mentioning that in their unit, they use Romson's drain. So this particular baby, to conclude the story, had a peritoneal dialysis, and we could, it was done for a period of around 4 to 5 days. Ultimately, this baby started producing urine, and the baby did well after that, as far as the renal perspective is concerned. So actually, we do conduct training in terms of some of the mannequins. We use a indigenous training methodology to train because they have to get trained before they go to the baby. So that might be helpful for something which the audience, the participants can do in their respective units also. So just to conclude 2-3 things. Can I ask Dr. Vishnu, we often talk about crosstalks between kidney and other organs. So what are the effects of AKI on other organs?
Yeah. Crosstalks in AKI, they do happen. AKI may drive other organ systems or vice versa, other organ systems driving the kidney. So many a times we off late from after COVID, we have been hearing about the cytokines and interleukins a lot. So a lung-focused inflammatory process driven by these cytokines, mainly interleukins, definitely worsens the lungs. And there are evidences that the duration of mechanical ventilation required in neonates who have had AKI are much higher. And again, the rates of BPD also has been higher. And also, we all know how challenging it is to strike a balance on the hemodynamics in these babies with AKI, depending on their severity. And other 2 more factors to points to add would be AKI do act as an independent risk factor for increased rates of intraventricular hemorrhage as well as hypertension, and also on the long-term neurocognitive outcomes of these babies.
Yeah, thank you. Actually, I'll just skip this question. We are kind of interested to know, can chronic kidney disease occur following neonatal AKI, and what is the follow-up you do as a pediatric nephrologist?
Yeah, actually, we don't have the incidence or prevalence of the neonatal AKI, I mean, the CKD following a neonatal AKI, but as far as our adult population is concerned, or our older children are concerned, about 30 to 40% of the children who have an AKI may end up developing a CKD or even an end-stage renal disease. And in fact, it all depends upon the staging of the AKI. That is, the more severe ones, that is a stage 3, might have the risk of developing a CKD more than a stage 1 or stage 2. And this all occurs because of the multiple factors, as we know, the altered-renal blood flow, the altered neurohumoral mechanisms, and the tubular dysfunction or the concentrating ability of the kidney, which is lost. And eventually, all of these things will lead to a glomerulosclerosis. And this will lead to proteinuria. And this proteinuria is basically the harbinger of the, what we say, a continued renal injury or development of the CKD. So what we need to stress upon is basically measuring the protein creatinine ratio, looking at the hypertension, and looking also at the renal function test. But mind you, the creatinine values rise very, very slowly. And in fact, the creatinine will start rising only when 50% of your glomerular damage. So you might find the creatinine values rising very, very late. So before that, you need to see for the other novel markers like cystatin C, which we don't do it very, very frequently, but at least we can look for a protein creatinine ratio and need to monitor a hypertension as well as the kidney sizes on our routine ultrasounds, which we do to look for the CKD in these patients. Or else what we can do, or what we end up is that we give these patients who are having the neonatal AKI as an adult CKD to our adult counterpart.
Yeah, thank you. That was useful. I think as we are doing for neurological follow-up, we need to do a renal follow-up also. So that is quite important to know. Any recent advances in the CRRT which you would like to share?
Yeah, actually, both these machines are basically literally a breakthrough as far as the neonatal CRRT is concerned. And both these machines are designed abroad in the Western world. The Nidus machine is designed in the Newcastle, as well as the Carpedium machine, which is designed in Italy. And still, it is not in much more, and even in the developed countries like US, these machines are not very frequently used. But I think so maybe in the next decade or so, we will be using these machines more frequently, because we can diagnose the children as low as 1.5 or 1.8 kgs, and we can go for a CRRT with this machine. So maybe in near future, though the cost of the therapy will be very escalated, but in near future, we might see these machines coming to the rescue of our neonates.
Yeah, thank you, Dr. Fagun. So can I ask all my panelists one take-home message from each before I conclude? Dr. Fagun, you can start. Take-home message.
Yeah, actually, so as far as the neonates are concerned, any children or any neonate who is admitted to the ICU is a potential candidate for developing for AKI. So an anticipation and prevention is the most important thing which we need to do if we don't want any adverse outcomes and we want to decrease the mortality and morbidity in our patients.
Yeah, thank you. So we need to anticipate like AKI by doing maybe a creatinine surveillance. So that was quite useful. Dr. Purva, one concluding remark for the audience. Dr. Purva. Dr. Vishnu.
Yeah, so have a close surveillance on the nephrotoxic drugs, adjust their dosage on those who are renally excreted, and avoid hypovolemia, strike appropriate fluid balance, and again, careful fluid restriction, especially in conditions like PDA and IVH and post-cardiac surgery babies, and always have a close watch on the renal function of these babies wherever to expect or anticipate risk.
Yeah, that was very helpful. I think basically the fluid. So we need to have a balance in the fluid. It should not be too less and it should not be high. Dr. Purva, are you there? Yeah, one concluding
yes,
remark.
I'm here. Yes, we should be like very careful, as the other two panelists have already said that anticipation is the key, and we do know that there are many risk factors. So we should be looking all those at-risk babies, and we should be actively looking for them that they could be having acute kidney injuries, and so it's better to have a baseline serum creatinine values for them after 48 hours of life, so that we can be able to monitor them accordingly with that baseline creatinine value. As we all as neonatologists, we are very like we know that we don't have to do very many investigations and don't lose the blood which these small babies have, yet we should have a baseline serum creatinine level, so that if a baby goes into AKI, we can be having those gradings also as per the serum creatinine values. So thank you. This was
Yeah, thank you, and thank you for allowing us to little bit exceed the time. I would like to thank the chairperson.
Thank you very much, ma'am.
So I think we would like to answer, like, if there are any queries.
Yes, madam. I would like to. Just a minute, ma'am.
Ma'am, the first question which was asked from Dr. Bharat was, are both parameters, creatinine and urine output, needed for classification? I mean, he wants to say if urine output fits in stage 3 and creatinine stage 2, which one to label, stage 2 or stage 3?
Dr. Purva, do you want to take that question? So usually we go for the higher grade. So basically, both according to the modified KITCO, like both criteria have to be taken into account. Urine output measurement can be need not be catheterized. It can be as a simple tool as measuring the nappy weigh every third hourly or so. So yes, both should be, and whichever is higher, we need to go and take that criteria.
Can I just chip into this? Yeah.
Yes.
So basically, as far as the urine output or as far as the criteria are concerned, the most important thing is basically the urine output, because many a times, especially in the newborns, as far as the creatinine is concerned, it might reflect the maternal creatinine, or in the very low birth babies, the physiological rise in the creatinine might occur for the first 24 to 48 hours, and this is because of the tubular immaturity, which can lead to the backlash of the creatinine into the blood. So again, the importance of the measurement of the urine output is stressed for. In fact, in the AWARE studies, it was found that about 67% of the patients who are having AKI were labeled only on the basis of the urine output, and these patients had a normal creatinine value. So this cites the importance of the urine output monitoring, and in fact, all the patients who are critically ill should have a catheter in situ so as to monitor the urine output. And the urine output monitoring, instead of even going at third hourly, I think so an hourly monitoring of the urine output is important. And sometimes the fall in the urine output, the grade of the fall in the urine output is also very, very important, rather than going on for the criteria like going less than 0.5 ml per kg per hour. So say, for example, if my child, which I'm seeing, is having a urine output of 3 ml per kg per hour, and 3 hours down the line, gradually if the urine output is falling from 3 ml to 2 ml to 1 ml, I should be very much alarmed that this child is probably developing an AKI, right?
And Dr.
I think till the AKI sets in, I think it should be the nappy weight, and once the AKI sets in, then it will be the catheterized. So we could conclude like that.
Then Dr. Prashant sir asking, first thing to give in hyperkalemia will be calcium gluconate, right?
Yeah, you have to stabilize, because the child is definitely having a tall T waves and also having a broadening of the voice. The ECG was also showing the PR interval, which was prolonged. So you need to stabilize the heart, because this child might any time go into the VTAC or ventricular arrhythmia. So stabilize the heart, you start giving calcium gluconate, give it over 10 minutes, the heart will stabilize. But the effect of the calcium gluconate will last only for 30 minutes. So you need to also insert other therapies where the potassium really goes down, because calcium gluconate will never lead to the potassium levels going down. It will only stabilize the heart.
Yeah, basically insulin dextrose has to be started as a like follow-up of that for hyperkalemia, because this is, and regarding resins, I think preterm baby, we need to be really careful, because there is an increased chance of compaction, and the gut will not be cooperative for giving resins.
Then Dr. Shwetal madam asking how to go for renal replacement therapy in case of peritonitis.
Yeah, peritonitis is not actually a contraindication. We can go for renal replacement therapy, a PD insertion. In fact, it will help because it will drain your infected peritoneal fluid. So definitely, it is not a contraindication. You can definitely go. We have the older children who are who are on CAPDs who develop peritonitis, and we do continue the dialysis in these patients. So peritonitis is not a contraindication. You can definitely go for peritonitis, and I think so that other indications like or other problems like severe pulmonary compromise or your abdominal issues, they really pose a significant challenge as far as your installation of your catheter is concerned.
Sir, can I ask?
Basically,
hello.
Yes.
I am Dr. Shwetal. Just what are the precautions would you like to tell us when we go for peritoneal dialysis in a case of peritonitis? Recently, just now I have a baby with a 4 create and severe anemia, AKI, sepsis, severe sepsis referred from outside with 3 PCV. So must be a shutdown because of this in transfusion also. So in that case, we started with PD and there is a severe peritonitis also. So what other, what you would like to add on to treat this peritonitis? Antibiotics are also going on.
No, the systemic antibiotics will work because in your PD which you are doing, acute PD, you will be giving a dwell time of 30-40 minutes. So you will not achieve enough concentrations in the peritoneal fluid if you instill the antibiotics. For antibiotics to act locally, you need to have a dwell time of at least 3 to 4 hours. So in these patients, you start PD, continue with your PD, and continue with your IV antibiotics depending upon the sensitivity report. That should suffice.
Okay, and even that child is having the baby, it's just a few days old baby, 4 HB and severe edema. The serum bilirubin is also very low. So we were like confused, should we continue with this PD? UOP is there, but 4 create is quite high and severe sepsis. So in that regard, whether we should go ahead with the PD?
Yeah, you can go ahead with...
In fact, like some of the babies who had NBC also, we have done peritoneal dialysis because they are preterm, they are extremely low birth weight. We do not have any option. And this fluid overload is the one which is going to be a detrimental thing causing pulmonary edema. So we need to take more fluid out in terms of edema. Of course, I think albumin, raising the albumin also will improve the colloidal and colloidal pressure. But however, like we do not have any options left in the extremely low birth weight babies, ma'am. So we have to resume to peritoneal dialysis only.
Thank you so much, ma'am, for
on one occasion, we have given intraperitoneal antibiotics because we could not take the catheter out. That again was one extreme low birth weight with NEC. So we had to continue dialysis because the baby remained anuric, and we gave both intravenous as well as intraperitoneal antibiotics.
Intraperitoneal, which antibiotic, ma'am?
Actually, that was showing a gram-positive organism, so we gave Vanco.
So that too in the renal doses, right?
Yes.
Because vancomycin again. Okay, fine. Thank you so much, ma'am.
Yeah, once dialysis is started, like we could resume depending on how.
Yes, we can resume to the original dose. Yes. Okay. Thanks for sharing, ma'am. We are just struggling with one baby, so I thought let me ask whether with the path is there or not. Okay. Thank you so much.
There is one question from Dr. Charul, madam. Sometimes in hypernatremic dehydration, we also get severe metabolic acidosis. How to go for acidosis correction and taking care of sodium values in hypernatremic dehydration?
Hypernatremic dehydration will always have an AKI, and this AKI is most of the times the cause of basically the metabolic acidosis, and the metabolic acidosis can be per se also because of the dehydration itself. So most of the times, if the acidosis is not very severe, correction of the primary pathology, that is correction of your hypernatremia, correction of your dehydration, and correction of and improvement in the renal functions will take care of your metabolic acidosis. If the acidosis doesn't get corrected, if it is very severe, if you need to do a lot of fluids, and if again the patient is developing oligoanuria, here you have to resort to a renal replacement therapy.
Actually, like I would be evaluating if there is a persistent metabolic acidosis. Actually, I would tend to like evaluate for other etiologies, including like IEM. We should not be missing because the baby had hypernatremic dehydration. So I will be thinking in that direction also in a hypernatremia with persistent metabolic acidosis, which is out with the clinical criteria. But as Dr. Fagun was mentioning, we also have had experience with like some severe hypernatremic dehydration where the baby has come with 20-25% weight loss, where your creatinine will be very high, but slowly as the sodium levels and the intake fluid balance are resuming, all will fall in place. But if it is not correcting, then I think we need to look for other etiology.
Yes, yes, definitely.
Sir, you are muted, sir. Dr. Dev.
Thank you very much, ma'am. There is no more question, and thanks for your useful inputs by experts, Dr. Uma madam, Dr. Fagun sir, Dr. Vishnu sir, Dr. Purva ma'am.
Thank you.
So, with the permission of Dr. Sandeep sir and Dr. Somsekhar sir, can we any comments or can we close the session, sir?
Yeah, so we close the session, and I am very much thankful to all the speakers. I mean, it was really wonderful. You know, I mean, till end, it's more than 2 hours. Still, so many people are still there. So over here, I just present a certificate of appreciation to our speakers. I don't know, my screen is visible.
Yes.
Yes, sir.
It's not moving. So the certificate of appreciation I have sent to all, to Dr. Rahul Verma, Dr. Tanushree, Dr. Uma, Dr. Purva, Dr. Vishnu, and Dr. Fagun. So thank you so much for being with us and enlightening us with the great knowledge. So
Thank you
so much.
Thank you.
Thank you.
Thank you very much. Thanks for the opportunity.
I would like to thank my panelists. I didn't get the opportunity to thank them. Thank you so much for being a part of the panel and putting a